I'm the new director for the cardiovascular services, and I get the pleasure of introducing Dr. Hagley this evening. Just a little bit about Dr. Hagley. He did go to medical school at Nebraska University, did his residency at Akron City Hospital in Akron, Ohio, studied cardiology in Washington University Medical Center at St. Louis, and actually did an interventional cardiology fellowship at Cardiovascular Institute of the South in Houma, Louisiana. So Dr. Hagley has practiced at Hutchinson since 2002, has practiced as an interventional cardiologist and also the medical director in the cath lab. Even though he's a cardiologist, he really has a love of treating peripheral vascular disease and limb salvage, has a distinguished reputation throughout the United States for his work in those areas. Today, I've had the privilege to work with Dr. Hagley for about 10 years and in the cath lab. And today I asked him, I said, what do you want me to say tonight when I introduce you? You know, what do you want people to know about you? And so he said, you know, he's an excellent conversationalist. He has a purple belt in Brazilian Jiu-Jitsu. And he is really, really good looking. So, but all kidding aside, you know, it's really been a pleasure for me for the past 10 years to work with Dr. Hagley. I've learned a great deal. It's been amazing to see the changes and the help that he's given people and the notoriety that he's given Hutchinson Regional Medical Center. So if everybody would give me a hand, it's Dr. Michael Hagley.
Thank you. That was actually a test. Aubrey mentioned she's new, and that was a test to see if she gets to keep her job longer than the last guy. I think she did great. Let's give her a hand. Well, this is quite a crowd. I don't think I've ever seen this many people in here. I appreciate you all coming. I had kind of a tough experience this morning. I was leaving the hospital and I was in the emergency department and I saw a sign advertising this. And it mentioned that there was a free meal and everything, and then it also said that there was a lecture, and I thought, oh man, I hate lectures. I can't stand going to one more lecture. And then it got worse because I read the line below that and it said by Mike Hagley. And I really didn't come with the plan of being a lecturer. I thought I would come and be a charming storyteller. That was my intent. I'm trying to redefine the way people see cardiologists. You don't hear the term charming storyteller applied to cardiologists very often. You don't hear charming, and when they call us storytellers, they don't really say it so politely. But that's what I'm going to do today. So don't think of this as a lecture. I want to just sort of take you through a tale of how interventional cardiology has developed, and specifically how it's developed in the way we treat myocardial infarctions or heart attacks. Can everybody hear me? Am I okay in the back? All right, so I told you I was going to storytell, and I'm going to take you back to warm weather, July 11th of this summer, and it was a day like any other day. My 7-year-old daughter, who happens to be back here, can you wave for us? All right. Was playing in a tennis tournament in McPherson. And so we'd gone up for the tennis tournament, and I was planning to meet a friend afterwards, and we were going to go to the range and do some target shooting after the tournament. And so that was the plan. It was a Saturday. It was going to be a nice, fun day. There's Lainey out on the courts. And about the time she was winding up, I got a text from a friend of mine, Todd, and he said, hey, can you look at this EKG? I thought, oh yeah, that's just what I want to do on my day off. Okay, send the EKG. Well, there's his EKG. Do we have any cardiologists here besides me? That's good. I can get away with a lot more this way. So he sent me this EKG, and that may not mean a whole lot to people here. But to me, I looked at that and said, well, that looks like my buddy's having a heart attack. Now, I knew earlier in the week he'd been having some back pain, and he'd been told by somebody he might have shingles. And I tried to reconcile that and say, well, you know, can shingles cause something like this? But I couldn't make it come together that way. So, and he was in Wichita at that time. And I called him and said, you know, you should go to the closest emergency department and get yourself checked out. He was in a physician's office at that time. And I said, you know, I think you're having a heart attack. So that was the conversation, and I figured, well, I put all of my guns and things in the car, and my ear protection and eye protection for no reason. So that was the way that day started. So I want to go through what we do when we treat a heart attack, but I want to go back in time a little bit. And there are really three eras of treating heart attacks that are pertinent to what we do today. The first is, what did we do in the early 1900s? Second, some things changed in the 1960s. And then there was a revolution that started in the 1990s. So I want to talk about each one of those eras. So let me just see if anybody has a guess. If it was the year 1915 and you had a heart attack, what would we do for you?
Not much.
I hear a lot of nothing.
I said not much.
Yeah, so the paper that defined treatment in that era was written by Dr. James Herrick, and it was published in the Journal of the American Medical Association in 1912. And the title of the paper is Clinical Features of Sudden Obstruction of the Coronary Arteries. So he does kind of sum up what happens in a heart attack. You have an artery in the heart that clots off abruptly, and then the muscle that that artery serves starts to die. Here was Dr. Herrick's prescription for treating the heart attack. The first was absolute bed rest. Then there was morphine and digitalis, two of the drugs that were available at that time. Digitalis actually started being used in the 1700s. They didn't know what it was, but they would have people suck on foxglove leaves until they started seeing yellow circles around things, and they were extracting the digitalis from the leaf. And then they would restrict the fluid intake. And the reasons that they did these things is that patients having heart attacks at that time had a lot of complications and a very high mortality rate. So the complications that they had included cardiac rupture here, and this is basically because they would kill off a portion of the heart, and then the heart's still contracted and it would just tear where it was damaged. Or sometimes they would form a defect between the left and right ventricles, which would be another lethal complication. And so the idea was that if you have them rest and do nothing, that they're going to have a lower risk of having these complications. And they would actually put them at the end of the hallway, away from the nurse's desk, so they could have a more restful environment. And so it was distressingly common for the physician or the intern or resident taking care of the patient to come in the morning and walk to the end of the hallway and find the patient in bed dead, because they didn't have heart monitors, and even if they did have heart monitors, they had nothing they could do if a patient had a lethal rhythm problem. So we really did a lot of nothing for heart attacks back then. I say we, they is what I should say. Well, the early 1960s marked the era of coronary care units and defibrillators. So everybody's watched TV, or most people have watched TV. and seen the doctor shows where somebody has a cardiac arrest and they run into the room with a crash cart and shock them. Well, it's not quite that simple. You had to have nurses who knew how to do this and knew how to read the EKG and tell you what the rhythm was. So there was a lot of logistical work that went into this, and you needed a defibrillator. So in the early 1900s, the defibrillator hadn't been invented. Well, here's the inventor of the defibrillator, Dr. Claude Beck. He was a heart surgeon at the Cleveland Clinic. And at that time, during heart surgery, a lot of these patients would develop ventricular fibrillation on the table, and they had no effective treatment for that. They would squeeze the heart and make it pump by squeezing it, but once your hand got tired, that was the end. So Dr. Beck developed this defibrillator that he could use to shock the heart and cause it to suddenly depolarize throughout the heart and then repolarize and start back in a normal rhythm. I like this picture because you can see the dial there where you increase or decrease the electricity has the label Almighty. So, and the other thing I like about this is the paper label that's taped on there. I don't know if we have any administrators here, but we went through a joint commission survey last week, and my guess is that paper labels taped on defibrillators wouldn't really pass the inspection today. The other fun thing about this is the defibrillator patches were actually silver spoons. And so they would connect a wire to those spoons and put the spoon on the outside of the heart and defibrillate the patient. And for a while in the 1950s, there was a trend when people had cardiac arrests that they would open their chest and then put these defibrillator spoons on there and try to resuscitate them that way. But that's not very practical most of the time. Once you open the chest, there's a lot of other stuff you have to do afterwards. So, has anybody ever heard the term Zoll? I know we have hospital workers here. If you've heard the term Zoll, raise your hand. It's a sort of generic term like Kleenex anymore. You know, not all tissues are Kleenex and not all defibrillators are Zolls, but they're oftentimes referred to as Zolls. Dr. Zoll was a physician at Mass General and developed the first external defibrillator that would allow you to put patches and lubricant on the outside of the chest wall. This is the first commercial defibrillator that was made and marketed. And this came out in the late 50s or early 60s. And once this was available, they felt like there was a need to develop intensive or coronary care units so that this technology could be applied effectively by staff who knew how to do it. And this is a Dr. James Forrester, who's really one of the most senior cardiologists around today, but he was instrumental along with other people in developing coronary care units and advanced cardiac care in that setting in the 1960s. All right, fast forward to the 1990s. What happened in the 1990s? What did we start doing?
Ballooning.
I heard one answer, ballooning. Any other guess? Bypass, any others? Heard stents, anything else? Transplant for a heart attack? So transplants, I don't know when Christian Barnard did the first heart transplant. I'd have to look and see when that was, but that wasn't used for treating heart attacks. Nobody's got the thing I'm looking for. What was it over here? Okay, well, you know, all those things are sort of correct, but not the answer I'm looking for. Defibrillator. Anybody heard of thrombolytics? Clot dissolving medicines? That was the first step. And I want to explain why. So here's a picture. This is about as technical as we're going to get today. I have to get technical and figure out where the button is on this. So here's a picture of a sliced up heart of somebody who died of a heart attack. And here, 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 there. Those are slices through a coronary artery that's clotted. This is what causes a heart attack, is a clot forms in the artery. A lot of people think that a heart attack comes when you just have plaque that gradually progresses to the point where it has a heart attack. That's not the case. You may have a very mild plaque, and then the plaque ruptures and forms a blood clot. So here's a cross-section through an artery under a microscope. Here's the plaque. You can see that plaque is small. Here's the blood clot in the artery. And right here you can see the plaque is disrupted or ruptured. And your body does what it has to do when you have a tear or a cut in an artery. It forms clots so you don't bleed to death. If you weren't able to do that, then every time you nick yourself with a razor, you'd end up eventually dying. You have to be able to form clot to get yourself to quit bleeding. So it's usually a small rupture that exposes the material here in the wall of the artery to the rest of the circulatory system. The body forms clot, and in this instance, it becomes a problem because it starts to kill off part of the heart. Here's a bigger picture showing the defect and the clot that's formed subsequently. All right, anybody know my connection to Dr. Saul Sherry? Was he a cardiologist? That's a trick question. He was not a cardiologist. He was a hematologist, and he practiced at Washington University Medical Center for a while. And he knew about this, that coronary arteries clotted because of, or that heart attacks occur because of clot in the coronary arteries. So in 1957, for the first time, he gave a clot dissolving medication to a patient having a heart attack. And did it a few times, and he thought that it worked, that some of these patients got better. Now, if you remember, I said the era of revascularization was in the 1990s, and I just said Saul Sherry did this in 1957. Why is that? Why did it take so long for things to shift? Well, the reason is he's a hematologist. Cardiologists didn't care what he had to say. So he reported this, and he was ignored by all of the doctors that took care of people having heart attacks. So, but what he said actually was correct. In the 1980s, there was a study performed and reported, and this was the first large-scale study that looked at this issue. And I know it's hard to read. We call this GISSI, G-I-S-S-I. What it stands for is Gruppo Italiano per lo Studio della Streptokinase nell'Infarctio Myocardio. That's why we call it GISSI. And this was published in the British journal The Lancet in 1986. And there were several similar studies, but here's what they showed. That if you look at, this, by the way, is as technical as we're going to get tonight. This is the lecture right here. So if you look at complication rates, or mortality, the worst survival or the highest mortality rate is in this group of people who received placebo. In other words, they got no streptokinase, they got no aspirin, they just were treated with 1912 technology, bed rest. The best survival was in this group of patients who received streptokinase, a clot-dissolving medicine, and aspirin, and they did very well. And then intermediate there, with almost identical curves, are the patients who received streptokinase alone or aspirin alone. So you can see that a 5-cent aspirin tablet, or maybe in the hospital a $10 aspirin tablet, is just as effective as a $500 dose of streptokinase. So, but the combination is better than either one alone. And so this was this is the first group of large-scale trials that looked at this issue and showed survival benefit from giving thrombolytic medications to treat heart attacks. And as a resident in Akron, Ohio, I had, I don't know if it was an opportunity or an obligation, but I was involved in signing patients up in the emergency department and actually physically give in some of their medication in the emergency department when they came in with their heart attacks. And I participated in ISIS 3 and Gusto during the data collection phase. All right, well, somebody else mentioned balloon angioplasty or ballooning, and that answer is kind of correct too. It came after the medication, or at least as it was applied to heart attacks. This is Andreas Grunzig. Dr. Grunzig was originally from East Germany and then went to Vienna, Austria to work and developed the idea of doing balloon angioplasty to treat coronary artery disease, and actually developed and put together balloons in the kitchen on the table with his wife and a friend of theirs. And these were the prototypes that they ended up using initially in dogs and subsequently in humans. And this was in the late 1970s that this was actually reported in humans. But Dr. Grunzig was a very conservative, careful person, and he wanted to help people, and that was important to him. But even more important to him is he wanted his technology to succeed. And so he wanted this to be applied in a very conservative way to the lower risk patients where there was a high chance of success and a low chance of complications that would sink his technology. So he was very cautious in that regard. And most other people in cardiology were. And there was the belief that this sort of thing should never be done to somebody having a heart attack, that it was just too dangerous, and that if you started putting balloons and things in there, you'd kill the patient. It was sort of like sailing west from Europe in the 1500s or 1400s, I guess 1400s. The belief was you'd sail off the edge of the earth, and here the belief was if you went in with a balloon during a heart attack, you'd kill the patient. So that was the problem at that time. Well, I mentioned Dr. Grunzig was conservative. Dr. Hartzler was not. Dr. Hartzler was one of the very early cardiologists to train with Dr. Grunzig, and we're getting closer to home now because Dr. Hartzler practiced in Kansas City at St. Luke's Hospital. And while Hartzler was conservative and cautious, or rather while Grunzig was conservative and cautious, Dr. Hartzler was a cowboy. I actually spoke with a surgeon who was here in town once who had worked with Hartzler and described him as having the courage of a burglar. And Dr. Hartzler would tell a story about the first time he did balloon angioplasty in a patient having a heart attack. Now, in those days, does anybody remember this, that at one time when we were doing balloon angioplasty, we had to have an operating room available with open packs and everything. And so this was back in those days. He had a patient for whom he'd done a heart catheterization for angina, and that patient had about an 80 or 90% narrowing in the right coronary artery. And so the patient was sent back to the floor and scheduled for a balloon angioplasty the next day. So the following morning, he received a telephone call from the floor saying, well, you can take that guy off the schedule because he's having a heart attack. So, you can't do a case on a guy having a heart attack, obviously. And Dr. Hartzler thought to himself, well, why is it that yesterday, when that artery was 80 or 90% narrowed, that this man was a candidate for a balloon angioplasty? And then today, because it's suddenly abruptly occluded, he's not. He said that just didn't make sense. So he said, I don't care what you said, get him down here now. And they put a guiding catheter in and advanced a wire across the narrowing and ballooned it. And he said it was the most amazing thing. And we take this for granted today because we do this so much, and everybody involved has learned this. But he said at that time, to see this man with a lot of pain and a terrible looking EKG and no flow down the artery, and to see suddenly you have normal flow down the artery, the EKG resolves like that, and the guy's pain goes away, was just the most amazing thing. And so from that day forth, Dr. Hartzler did nothing but balloon angioplasty to treat heart attacks. And that was sort of the controversy at the time I was training, is which one of these treatments is best. So there were more studies done. The nice thing in cardiology is there are plenty of heart attacks out there. So we can do studies on top of studies. And so we're randomized to be treated with either thrombolytic or clot dissolving drugs or to be treated with balloon angioplasty. And what they found is that if you look at mortality rate for an acute myocardial infarction, that the thrombolytic drugs, which are far better than nothing, are worse than the balloon angioplasty outcomes. So balloon angioplasty is associated with a lower mortality risk and a lower rate of a combined endpoint of death and repeat myocardial infarction. This graph kind of sums it up too, that when you give people thrombolytic drugs, you open up slightly more than half of the arteries at 90 minutes, but you open up more than 90% of the coronary arteries. And in fact, now we probably open 98 or 99% of them successfully. And you have a lower mortality rate when you do balloon angioplasty. And so in hospitals like this, balloon angioplasty should be the treatment of choice for somebody having a heart attack anymore. It isn't always, but it is here, and that's based on having a hospital that's committed to making those resources available and having really dedicated technologists and nurses in the cath lab and dedicated cardiologists so that we're able to offer this treatment 365 days a year, 24 hours a day. This is what we do if you come here with a heart attack. The national standard is that you're supposed to be able to get people into the cath lab and have the artery open within 90 minutes of the time they get to the emergency department. And I think our average time the last quarter was 57 minutes. Is that about right? Somewhere in there? 58, Aubrey says. And that's one of the benefits of being in a smaller community is we don't have traffic jams and things like that that keep people from getting in. Well, let's go back to Todd. I said I was telling stories. Let's figure out what we're going to do for him. We'll make it a multiple choice, and we'll see what people think. Option A, thrombolytic therapy. Option B, angioplasty and a stent. Option C, bed-rest and morphine. D, none of the above. He messed up a perfectly good trip to the range. So who says A, thrombolytic therapy? Nobody. B, angioplasty and a stent. All right, so that's what we're going to do. So I drove down here. I said I told him go to the closest ER. And he was in Wichita, and he said, I don't think so. I'm driving back to Hayes. So against my advice, and I want to be real clear about that, he came back here. And I knew from his EKG he was having a heart attack involving this artery on the front of the heart called the left anterior descending artery. Here's a schematic of what happens. You have a plaque there. It ruptures, you form a clot. So Todd came in, we took him to the cath lab. Here's one of our first pictures. You have nice, normal, tapered arteries here. And you have an artery that's completely plugged right there. That should be a big artery, and instead it's just a nub. So this is a fairly high mortality risk type of heart attack. Here's my guiding catheter. I know it's probably hard to see, but there's a wire here, and there's a balloon blown up right there. And here's that same artery after the balloon. Here's before, here's after. And another view. There's a nub right here, something missing. Here's what was missing there. You can see the wire tip here, and this artery is open. So I told you he had back pain when he came in, and after we finished, I asked about the back pain, and he said the back pain was gone. Now, he'd had these symptoms for a while, and at first his heart muscle was kind of weak, but it's gradually improved, and it's back in sort of a low normal range, and he's been through cardiac rehabilitation and risk modification and things like that, and has done very well. Can anybody read that? There are two sides to every story. So I've told my side. And now I'm going to move on and I'm going to introduce you to Todd Brown and let you hear his side of the story. So I want to tell you a little bit about him, that Todd has a history of working as a cardiac nurse and then subsequently sold and serviced pacemakers and then sold an atherectomy device that we use in peripheral arteries and in coronary arteries. And that's the job he was at the time all of this took place. And now he works here in the risk management department at Hutchinson Regional Medical Center. So I am going to step away from the microphone, probably what you've all been waiting for, and let Todd Brown take over. So let's welcome Todd.
I will definitely have a different side of this story. As Dr. Higley alluded, I was still consider myself a cardiac nurse. I know what signs and symptoms of a heart attack are, right? Well, not really. I was in Wichita when this was diagnosed, and I actually told him no when he said get to the hospital, get to the closest ER, get looked at. I told him no. I want to go where I know I'm safe, and I know the people that are going to treat me, the folks in the cath lab. I know those folks. They do a nice job. They do the best job of anywhere around. So I got in my car, called Dr. Higley about the time I passed Haven, checked in with him. He asked me to call him. I called him, and we met in the emergency room. So from there, this is kind of my story. It'll be hopefully a little bit more humorous than his. Maybe. So these are three, you notice there's 4 in the picture, but there's 3 that are really important to me. This little guy, find my button here, this little guy is our new puppy. He's an idiot. He will eat anything, and he drives us all nuts, but this is my family. This is why I came to this hospital to be treated. I've been to every cath lab in the state of Kansas as a sales guy, not as a patient. I knew where I wanted to be. Here is home. And as a consequence, that's why I told Dr. Higley, no, I'm not going somewhere in Wichita. So I had a little bit of an excuse. So my travels through the hospital are normally upright and walking, like you all came in here today. I want to show you a little different perspective of what I got to deal with when I came in as a patient, one of the sick people. So, does anybody recognize that? I tell you, it's hard to take a picture that's blurry, so I think Dr. Higley and I were actually kind of running down the hallway trying to take pictures and make them blurry, because that's what you see. You know, that's when I realized, heck, I'm sick, I'm a patient. So that is from the emergency room. I need to back up. So at the emergency room, Dr. Higley had notified the cath lab staff and the ER that I was coming in. And I walked in, I'm like, hey, here, hi, I'm checking in, no big deal. And they took me into my room, walked in, and then it was like a hornet's nest. Everybody had their thing. It was a well-oiled machine of everyone knew what they needed to do. And I think it was maybe a minute after I got in the room and they started doing things, Dr. Higley shows up. I'm like, this is awesome. This is pretty neat. And then I realized I'm looking at the ceiling again going, I'm the patient. I'm not getting ready to help with a procedure. So we left the emergency room and tooled on down the hallway. So that's my first picture of the ceiling. Doggone it. Sorry about that. And then that's my view of the cath lab as I'm rolling in. Okay? Now, for you folks who haven't had this, that would be your view. Okay? So I rolled into a department that I was very familiar with. You know, I sold pacemakers for about 10 years, worked in the peripheral vascular space for about another 3.5-ish. So, 13, 14 years I've been coming to this hospital as a sales guy. And I've always known that the care was great here. And this is one of the reasons I decided, yeah, I'm coming to this place to get worked on. And guess what this is?
More safe.
More ceiling, correct. This is a spot that I'm very fond of. When I sold pacemakers, there's a vent right around here that Dr. Hegley seems to like the temperature in the room to be right around 59 degrees. And the wind's blowing at probably 15 miles an hour. And he's over in a gown and all warm and gloves and all the good stuff that he needs on. And I'm standing by my pacemaker programmer freezing my butt off. So now I've got a different perspective. This is when it hit me hard that, yeah, I'm having a heart attack. I believed him from the first diagnosis, but I'm in the cath lab now. Weird feeling. Oh, by the way, I'm 47 now. This happened when I was 46. Okay, little young, don't you think? Okay. So again, here's the last thing I remember seeing. Thank goodness to the folks in the cath lab. I remember looking up, and I explained this to Dr. Hegley. I said, I remember looking up and seeing this, and it should be this. And about that time, everything got dark, and I went to sleep. I woke up to Dr. Hegley saying, hey, how do you feel? How's your back? Feel great. Well, wow, that was pretty cool. So, you look at what he was talking about, bed rest. I called it, when we were working on this talk, being put out to pasture. I don't want to go to the end of the hole. I'd really like to wake up from my family and kids. That's important. So luckily I knew where to go. So waking up after seeing this, you have all sorts of emotions that run through your body. And this brings me to my next favorite group of folks, the cardiac rehab team. I didn't want to be there. I mean, I'm 46 years old, I shouldn't have a heart attack. I did. That's when you realize you need to do some risk modifications, some changes in how you look at things, the food you eat, the activities you do. As my sales job, I could travel 200 miles, maybe a little bit more than that in a day, and I might walk a half a mile. So I was sitting on my behind in my car getting absolutely no exercise. So when it was determined, yep, you need to go to cardiac rehab, with the encouragement of my wife, my family, mom and dad, Dr. Hagley, cath lab staff, it was time to jump in, get after it. I had an enemy in the cardiac rehab, and it was this guy, number one. I was bound and determined to break that thing. Yeah, it was heavy. I've lost some weight, but that's not how you break it. I wanted it until it was dead. I wanted to run it until it was broken. And first day I got in there, I was so proud of myself. Not really. I went about 20 minutes flat, and I was sweating like a monster. And every day I'd get done, I'd send Dr. Hagley a text and just say, hey, 25 minutes, I don't know, 1.2 miles. I look back on that now going, wow, that wasn't very much. Towards the end, I was able to get to the point where I'd start a little early in the class, and then finally one of the cardiac rehab folks would tell me, hey, you need to leave. And that happened twice, I'll admit it, but I wanted to get better, and they encouraged me and helped me through all the challenges to get through and get better. But it was nice. I was able to get to the point where I could walk as long as I wanted and then some. And still able to do it, which is important. So this is a picture from November of last year. And this is of a hunt I went on in November, right before Thanksgiving. This was something I've always wanted to do. It was actually a mountain lion and a bear hunt. And if you don't like hunting, I apologize, but I'm a guy, I've got a bucket list, and my bucket list is really good now. I want to do some fun things. But this was in New Mexico, and obviously got this all cleared through Dr. Hagley, my primary care guy. Everything was good to go. My wife gave me the thumbs up, thanks honey. And this is a picture of actually my guide at the top of the hill. It was myself and my guide, And sometimes we had 4 mules, or he called them donkeys or other things we're not going to talk about. And this was an interesting picture for me. I didn't have cell phone coverage for 80% of the trip. I was used to running and gunning and all these extraneous stressors and things, and stood at the bottom of the hill, and very seldom were we actually on the mules riding. Thank goodness, because that hurt my behind. So I'm sitting at the bottom of the hill. Here's my donkey ear. And I'm looking up this hill, and nothing in New Mexico in the area where we were hunting was flat. Everything was a chore to get up and down. And I can say I was not winded once. It was amazing. And that was from all the retraining I had to go through with cardiac rehab, lifestyle, dietitian, the whole 9 yards. So this is kind of the journey of me at the bottom of the hill, July 11th, and here's where I'm going to be, and that's where I was. So kind of a sentimental picture. Yeah, it's a goofy-looking guide and a couple donkeys, but, it sets well with me. And this brings me to risk modification end. I had a very stressful job, and I had an opportunity to join a healthcare setting that has actually done my family very well over the years. It was my chance to give back. Had an opportunity, I jumped at it. Done with the old, this is a different kind of stress. I'm excited to actually help give back to the community, for the community that's helped my family and I get where we're at today. I have to say, don't do what I did on telling your doctor no. The sad thing is I've got a little bit of different experience being a cardiac nurse. If he tells you to do something, it's probably a good idea. It's the best healthcare I've been around. I'm proud to be part of this community and this hospital, and I want to tell you all thank you very much for listening.